Hi everyone, I'm Gianna Babin and I'm going to be presenting solutions for Case 1 and Case 2 within Unit 4 today. So to start, Case 1 consists of a newborn girl who appeared normal at birth, but then within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. A full blood workup was ordered for this female, and the initial blood ammonia level was elevated at 314, and it continued to rapidly increase to 600. The urine orotic acid level was marked elevated at 473, and the plasma citrulline level was normal at 10. So I believe that plasma glutamine would be the best diagnostic tool to be able to differentiate between a urea cycle disorder and a beta oxidation defect. Glutamine is a non-essential and non-toxic amino acid that takes part in the detoxification and transport of ammonia. In a urea cycle disorder, along with the rise of free ammonia, plasma glutamine levels would also be elevated. On the other hand, glutamine levels are completely normal in beta oxidation defects. This case is consistent with ornithine transcarbamylase deficiency. This is a urea cycle disorder that is characterized in females by hyperammonia, lethargy, and apnea, which is present in our patient that we see. In conclusion, the deficiency of ornithine transcarbamylase will result in the accumulation of carbamyl phosphate in the mitochondria, which then continues to leak in the cytoplasm, where it is then redirected into pyrimidine synthesis, resulting in the levels of orotic acid in the urine to increase. The increase in orotic acid level helps me to be able to distinguish between orotic transcarbamylase deficiency from carbamyl phosphate synthase 1 deficiency. So in all, the most likely deficient enzyme in this case will be ornithine transcarbamylase, and the enzyme least likely to be impaired would be carbamyl phosphate synthase 1. Continuing on with Case 2. So Case 2 involves a 4-day-old patient, infant patient A, being followed in my clinic. Her birth weight was 5.9 pounds, and the pregnancy and the birth were totally normal. Results from the newborn screening demonstrated a phenylalanine level of 6.6 and a presumptive diagnosis of phenylketonuria (PKU) was made, and additional samples were obtained for further analysis. Parents deny a family history of PKU, and the dietary restriction therapy was initiated at 14 days old, with a good response of plasma phenylalanine levels that dropped to within normal range, which is about 1.65. Another infant, patient B, is also being evaluated for suspected PKU. In this patient, BH4 loading tests are performed. BH4 loading tests are performed on both patients. So in phenylketonuria, there is a deficiency in the gene coding for phenylalanine hydroxylase. This deficiency would result in phenylalanine hydroxylase not being produced. So tyrosine would then become an essential amino acid. Phenylalanine cannot be developed in the body, so this builds up in the brain, leading to several symptoms. These symptoms of phenylketonuria can include stunned growth, seizures, tremors, and hyperactivity. An additional cause of phenylketonuria is a deficiency of tyrosine, which is used for the synthesis of thyroid hormones and melanin. So in patient A, the blood levels of phenylalanine is increased, but controversially in patient B, it's decreased on the loading of BH4. Given this information, patient B has a BH4 deficiency, while patient A has a deficiency in phenylalanine hydroxylase.